This will be part 1 of the neurolocalization lecture series. In simple terms, with neurolocalization, patients can be classified as either having a lesion within the central nervous system, which would include the brain and spinal cord, or the peripheral nervous system. With the peripheral nervous system, that can be further divided into either the nerves, muscles, or the communication between the two, the neuromuscular junction. To break things down further, the brain can further be divided into the forebrain, the brainstem, the cerebellum, and the vestibular system. Remember that with a vestibular lesion, a central lesion means a brainstem localization, paradoxical vestibular disease is a cerebellar localization, and peripheral indicates either cranial nerve 8 dysfunction or a lesion to the inner ear. For the spinal cord, the 4 areas of localization in the dog and cat are C1, C5, C6, T2, T3, L3, and L4, S3. So just to review, there are 4 intracranial localizations: forebrain, brainstem, cerebellum, and vestibular, and 4 spinal cord regions of localization: C1, C5, C6, T2, T3, L3, and L4, S3. Some terms that you might hear are prosencephalon. This includes the cerebrum, also known as the telencephalon, and the thalamus, also known as the diencephalon. In the brainstem, there is the mesencephalon, also known as the midbrain, the ventral metencephalon, also known as the pons, and the myelencephalon, also known as the medulla. The cerebellum is the dorsal part of the metencephalon, and with the vestibular system there is central and peripheral. For the spinal cord, there are areas known as the intumescence, which we will discuss later on. Another concept to be familiar with is decussation, which is the crossing over of information from one side of the brain to the other side of the body. This is true for motor and sensory information. This decussation occurs at the level of the thalamus, so whenever we have a forebrain lesion, the neurologic abnormalities or deficits should be on the opposite side of the body or the contralateral side. A lesion caudal to the thalamus, such as the brainstem, will cause deficits on the ipsilateral side. With central nervous system lesions, both motor and sensory can be affected, where the peripheral nervous system could be just motor or just sensory. Now please understand that these are general rules, and there are always exceptions to the rules in medicine. Other terms to know: encephalopathy is disease of the brain, myelopathy is disease of the spinal cord, and the peripheral nervous system could be a neuropathy if it is just the nerve, a junctionopathy if it is at the neuromuscular junction, or there are conditions where just the axon, myelin, or nerve root could be affected. Going through more terminology, we need to discuss upper versus lower motor neuron. And on the left of the screen, reflexes atrophy and tone are listed, which will make sense shortly if you haven't heard these terms before. On the top right, we have the spinal cord, and we have taken a cross-section of the spinal cord in blue, at the level of the intumescence, or the C6, T2 region. Looking at the cross-section, we can divide the spinal cord into sensory dorsally and motor ventrally. In other words, when sensory information, such as pain, is traveling from the limb to the spinal cord, the information will go up the dorsal nerve root and into the dorsal region of the spinal cord, where it then travels to the brain. Motor information from the brain travels through the ventral region of the spinal cord, then in the ventral nerve root and down the appropriate nerve. When this pathway is disrupted at the intumescence, so either the C6, T2, or L4, S3 region, lower motor neuron signs are present, and when the lesion is at C1, C5, or T3, L3, upper motor neuron signs are present. And we use reflexes atrophy and tone to differentiate this. Starting with reflexes, specifically the withdrawal reflex, here we pinch the animal's toe, and that signal will travel up the nerve of the limb and then up the dorsal nerve root. Now, when we are talking about pain perception, this is the signal of pain traveling up to the brain, which is not the same thing as a reflex, and I cannot stress this enough. In other words, we can transect the spinal cord and the reflex will still work. This is because, for a reflex, once that signal is in the dorsal region of the spinal cord, the signal travels directly from the dorsal region of the spinal cord to the ventral region, forming an arc, and then that information travels down the ventral nerve root to the nerve itself, causing that limb to flex. This arc has no cortical input, and if the reflexes are normal to increased, the lesion localization would be cranial to the C6, T2 region, so forebrain, brainstem, cerebellum, or C1, C5 spinal cord. If the reflexes are decreased to absent, the lesion has to be C6, T2. The reason why this occurs is because of how neurons function. Within the region of the intumescence, there are lower motor neurons which are very excitable, meaning without influence from the upper motor neurons, such as from the brain, they will have exaggerated responses. Because normally there is the upper motor neuron signal going to the lower motor neuron, it will decrease the response of the lower motor neurons, allowing everything to function smoothly. So the upper motor neuron can be thought of as putting a speed limiter on a car, so only so much excitement can occur. With an upper motor neuron lesion, this speed limiter is removed, and when a reflex occurs, the response is going to be exaggerated. However, with a lower motor neuron lesion, the neuron itself cannot function normally, if at all, and the reflexes will be decreased to absent. This is like hitting the brakes on a car. To summarize, reflexes are normal to increased with an upper motor neuron lesion and decreased to absent with a lower motor neuron lesion. This same concept occurs with tone as well. To go through this in more detail, here we have the nervous system working in harmony with the upper motor neuron coming from the brain communicating with the lower motor neuron going to the intumescence of the thoracic and pelvic limbs. If there is a C1, C5 myelopathy, this disrupts the upper motor neuron information to all the limbs, resulting in increased excitability of the lower motor neurons, meaning reflexes and tone will be increased in the thoracic and pelvic limbs. Or the patient is upper motor neuron in all four limbs. Looking at a different lesion localization, now we have AC6, T2 myelopathy. This means the lower motor neurons from the cervicothoracic intumescence are directly affected, resulting in decreased reflexes in the thoracic limbs. But because the upper motor neuron signal is disrupted to the pelvic limb, the reflexes and tone will be increased in the pelvic limbs. With AC6, T2 myelopathy, the patient will have lower motor neuron signs in the thoracic limbs and upper motor neuron signs in the pelvic limbs. Continuing down the spinal cord, once again we have everything in harmony, the upper motor neurons communicating with the lower motor neurons. However, now there is a disruption in the T3, L3 region. The thoracic limbs are unaffected because there is no disruption to the lower or upper motor neuron. However, the pelvic limbs have lost the upper motor neuron signal, causing the reflexes and tone to be increased. So the patient has upper motor neuron signs in the pelvic limbs. Lastly is the L4, S3 myelopathy. A lesion to the lumbosacral intumescence will result in decreased to absent reflexes and tone in the pelvic limbs, and the thoracic limbs will be normal. In other words, the pelvic limbs have lower motor neuron signs. A brief work on atrophy. Generally, if atrophy is mild and chronic, a lower motor neuron disease is unlikely. This type of atrophy occurs with orthopedic disease or upper motor neuron disease. However, if the atrophy is severe and acute, this is indicative of a lower motor neuron localization, in this case a right-sided C6, T2 myelopathy, or potentially a brachial plexus neuropathy. Generally, reflexes and tone are more helpful for localization because patients present more commonly in the acute phase. However, atrophy can be helpful in more chronic cases. To bring part 1 to a close, one final thing to remember is that the localization of C1, C5, C6, T2 and so on are localizing to spinal cord segments and not vertebra. Although in the thoracic spine the vertebrae line up nicely with the spinal cord segment, in the cervical spinal cord this is not the case because there are 8 cervical spinal cord segments but only 7 cervical vertebra. So when a C6, T2 lesion is localized, the lesion could be located as cranial as the C4-5 disc space. This gets even more off with the lumbar spinal cord segments because the spinal cord ends within the L6 vertebra, meaning an L3-4 disc herniation could cause L4 signs, and an L5-6 disc herniation could cause sacral signs. It is also important to take into account how the cauda equina extends past the spinal cord and how a lesion of the cauda equina could present versus a true myelopathy. But for now, we will end part 1 of the neurolocalization lecture. From Vet NeuroJar, keep those minds inspired, hearts light, and tails wagging.